I will say I'm really honored to be here and to be asked to talk about this topic. Does this sound okay? This is not projecting. This is, yeah, she doesn't know. And so I will say I am honored to be here. And at first it really stressed me out because there's so much advertising and it really was intimidating me. And then I realized, wow, I have a captive audience that can listen to the things I'm passionate about for like 30 or 45 minutes. And my friends give me 5 to 7 at dinner conversations. So this is exciting. I stopped being nervous and just said, I'm going to talk to you about some stuff. All right, so the introduction, I don't need to introduce myself any further, except there are some things that you may or may not know about me. I am from Appalachia. I was born in Boone. Both of my parents are from this region, and that's an important part of who I am. I'm a first-generation college student, spent a lot of my childhood on a farm. You see me driving a tractor here. I really am intimidated by tractors, and I'm not good at it, but I'm really good at driving a team of horses. And so that part of my background has everything to do with the work that I'm doing today. And I have a heart for the Appalachian people. I believe, like me, we can be resilient, we can be strong. My mother, I am the oldest child of a parent who had alcohol use disorder. And we are strong, resilient, healthy people. And there are a lot of things that are negative about Appalachia, and you're going to hear some of those in my data. But know that at the heart of me, I believe in this area, and I'm going to talk a lot about it. All right, so here's an overview. I am going to talk some data talk. I know that that's not informal or conversational, but it's important to understand this epidemic. And then I'm going to walk you through our response. We try not to respond to this by doing just one thing. We try to think of the entire continuum of disease, and I'll walk you through what that is and what that means. And then new directions, some new exciting things for our center. So I'm going to share all of that with you, and of course there'll be time for questions at the end. So I want to start by framing this. In 1980, there was a letter to the editor in the New England Journal of Medicine that said, essentially, opioids are safe and very few people become addicted. And we know that that's not exactly the case. This was a record review. It wasn't a peer-reviewed study. It was an observation of patients, many of whom were end-stage cancer patients. And this tiny little paragraph has been cited over 600 times now, and especially after the formulation of OxyContin. So that in conjunction with a time when we were really wanting to address pain, we were talking about pain as a fifth vital sign, and pharmaceutical companies who were making some really, actually excellent pain-relieving drugs. All of this happened at one time, and then we began to see just a mass distribution of these drugs and sort of a misunderstanding about prescribing them. So today we are losing about 130 Americans each and every day to opioid-related overdose. That's a lot of people every day. It's 3 in the state of Tennessee. Now, I want to be sure that we understand all what opioids are. So opioids can be prescribed pain relievers that are opium-derived, like hydrocodone, Percocet, Vicodin. Those are opioids. There are also synthetic opioids that are not derived from the opium. They're synthetic. They're made from other chemicals. They are prescribed and illicit. So if you've heard of fentanyl, fentanyl is available as a prescription. It's also available on the black market, illicit. It's very strong, and carfentanil is even stronger. This is part of the reason that we're driving up overdose deaths. And then heroin, that's also an opioid. So just understanding that they're both prescribed and illicit opioids. So this is the story of the epidemic in our country. We see on the left, oopsie, oh, what was that? Oh, good, that didn't last. In 2003, there were very few counties in the nation that had drug overdose death rates higher than 30 per 100,000. The only place in the nation with contiguous or touching counties that had that high rate were right in Appalachia. So we see this right here. So we knew then that there was a problem. 2016, you can see that the story is much different, and many counties have much greater than 30 per 100,000. Recently, the DEA released their database that showed where all of the pills were shipped in our country, and it's a very sad story that we see here on top. These are places in dark red that had 150 pills per person, that means man, woman, and child, in the areas of dark red across our country over a 6-year period. Even sadder is to look at how identical the map of overdose deaths looks to where those pills went. You could practically overlay them. And so it's a very sad story. of how this epidemic reached these proportions. This is a hyperlink, and if anyone wants access to the slideshow later, you can click, and there's a story of Norton, Virginia in that hyperlink. There is some good news. There are many states in the country whose overdose death rates are on decline. The blue states are states that in the past year, their overdose rate declined, and there was a positive change. The darker blue, the better the change. The orange states, unfortunately, are areas where we continue to have rising overdose death rates, and Tennessee being one of those. So there have been 3 waves to this crisis. The prescription crisis that we were talking about earlier, we see that as this purple line, starting around 1999 to really go up, and now it's sort of plateaued. As we began to see that this was a problem, we put controls in place. Doctors stopped overprescribing, and we put some controls into place, but unfortunately, even though the supply of prescribed drugs was controlled, the demand was still there, and many people were dependent or addicted, and so in came the Mexican cartels who were well poised to provide heroin, and then later, so we see that uptick here in heroin in 2010, and right behind it came the wave of synthetic opioids that really much stronger drugs that were available, many of which are coming from China and other places. So these 3 distinct waves, we're looking at a different wave now. I don't know that we'll call it a different wave, but a rise again of methamphetamine and use of both substances, which is a little different than what we've seen in the past. And so we're seeing a lot of folks who are using both substances, and there's some qualitative work being done to ask those active users, why are you using both? And they're saying, well, they're both affordable. Most of our dealers have both on hand. It's a balancing effect. Opioids are depressants, stimulants are stimulants, and so that it balances that effect. And if we're seeking to numb out or have that euphoric effect, many will take whatever's available. And so availability and balancing effect are some factors. If you haven't read Dope Sick, I highly recommend it. It tells the story of Appalachia, Norton, Virginia, other places, and doctors close as Abingdon, Art Van Zee is one, who sounded the warning bells many years ago and were trying to say, we're going to lose hundreds of thousands of people if we don't do something different. Unfortunately, not everyone listened. Very few people that made decisions listened at that time, and we are where we are now. But our team and others are in this book. It's really good. All right, so a little bit about the difference in Appalachia and the country. Now, we know that opioid misuse, substance misuse, is a symptom of underlying problems. Our communities have lots of problems. We have income inequality. We have poor health outcomes. There are so many things, educational attainment happening in our country. This is a symptom. And we also know that for the first time in our history, our life expectancy is declining. So folks began to look at that. What's happening? Why is this happening? So Ann Case and Angus Deaton, who I think are married, but I might have dreamed that. I'm pretty sure that they are. But they did an interesting study that said what is increasing morbidity and mortality among non-Hispanic whites, and what they found is 4 main causes. You can see here that lung cancer, diabetes, those things are plateauing or going down, while 4 main causes: overdose deaths, suicide, alcohol-related problems are all on the rise. And so those are driving overall mortality and morbidity. Now, we wanted to know some folks at NORC. It used to be called the National Opinion Research Center. It's not anymore. They just say NORC. But a group there wanted to look into the Appalachian, how was this affecting Appalachia? And what you see here is that in Appalachian counties, your diseases of despair are higher than in other non-Appalachian counties. So we are a significant factor in this change in our country. There's a really cool overdose mapping tool where you can look at overdose death rates in Appalachia, overlay employment, education, other factors to sort of see all of the different things that are playing into this epidemic. It's a really cool tool. It's hyperlinked here. So if you have the slideshow, you can play with that tool. I'm going to walk you through just a little bit of Tennessee information. Know that all of these numbers are people, right? I never want to forget to say that all of this data, the 130 people a day, they are our friends, our family members. So they're real people that this is happening to. And many of you in this room might have experienced the loss of a loved one, or you know someone who's struggling with this. So I do like to keep that in mind. These are the drug overdose deaths in the state of Tennessee. We had 1,818 people who died from a drug overdose in 2018. The dynamics are changing a little. You can see that the numbers who the primary substance was prescribed are going down. Our stimulant overdose-related deaths are going up, as are fentanyl and heroin. This is just another look at that same data, the increase in stimulant-related overdose deaths in our state. We also know that neonatal abstinence syndrome, or neonatal opioid withdrawal syndrome, as it's also called, has been a serious concern in Northeast Tennessee. Luckily, that is also in decline, I should say. These blue bars are at August of 2019, as compared to these higher numbers that were in previous years. We're getting women stabilized, we're knowing how to intervene earlier and get folks into treatment. We also know that in Northeast Tennessee, there's a higher rate of injection drug use related to opioids. We can see that these darker colors mean that more folks are injecting drugs in our region than in other parts of the state. And with that comes other health consequences like hepatitis C from sharing needles. We have very high rates of acute hepatitis C in our region. And the reason that's important is opioid injection drug use and hepatitis C are harbingers of potential HIV outbreaks. And in Scott County, Indiana, in 2015, there were over 200 cases. This slide sort of was earlier, 200 cases of HIV in a county that usually sees 4 in a given year. It was directly related to sharing needles in order to access Opana, which is a very strong opioid pain reliever. There's some fancy network analysis going on to sort of see how users move through a social system and how this spreads, but there's a lot to be learned from that. And I did spend 4 or 5 days there, and that community has really responded, and they have some amazing, resilient stories to share. So, of course, the CDC was like, whoa, this is really dangerous. This could happen in other places. We need to find out what's going on. So they did an analysis to see what other counties in our country were vulnerable for that kind of HIV outbreak. So 220 counties in our nation are in the top 5% most vulnerable to this type of outbreak. 41 are in the state of Tennessee. So the pink dots are the counties most vulnerable. The green dots are where syringe service programs, the best practice to prevent an HIV outbreak related to injection drug use, are in green dots. So how many green dots are in Tennessee at the time of this study? One. In 41 counties. Is it in the county that was in the top 5%? No. So that was a problem. We now have 6. And so during that time, we wanted to know, well, what are our state laws? Why don't we have syringe service programs? If we know that we're, ripe for this kind of outbreak, what should we do? So our Applied Social Research Lab here, for folks standing in the back, there are seats up front, and I don't mind if you come, and there's a couple up here if you want to. I feel bad for you back there. So we were able to add questions into the Tennessee poll that our Applied Social Research Lab does, and we wanted to know what citizens in Tennessee. So this is a Tennessee poll. You call on the telephone. There's 600 to 800 people who take this, and we said, first, are you concerned that there's a hepatitis C or an HIV outbreak in your community related to opioid injection drug use? And we wanted to know what they thought. So these bottom bars show that 67% and 63% of the people had no idea that this was a concern. And this was after the CDC report was released. Then we said, okay, if it was proven that syringe service programs prevented hepatitis C outbreaks and HIV outbreaks, would you support them? And overwhelmingly, 74% said yes. So we thought, well, maybe our elected officials don't know this. So I wanted to be sure that they did. And so we created a policy brief, and every member of the Tennessee House and Senate got this in hard copy and soft copy. So we now have 6. I don't know if it made a difference. I didn't hear from anyone, but I thought they should know. Okay, so we know that at the federal level, we've been responding for many years. In 2016, Obama signed the Comprehensive Addiction and Recovery Act, CARA, and Congress signed in the Cures Act. We know that President Trump also declared a national emergency and commissioned a group to provide some recommendations about what we should do. We know that in Tennessee, 2 separate governors have put forward plans that you see here. Some have had funding, and we're getting a lot of funding from the federal government now to intervene. We have peer recovery specialists. We have more access to treatment. There are good things going on in our state. Okay, so now we're at the place where I'm going to share with you what we're doing as a center. And so you're going to hear them say the word DIDARP a bunch. Well, in 2012 is when we started addressing this problem, and we got our first NIH grant that built the work that came after. And it was called DIDARP. So when you hear that in this video, that's what they're talking about.
the epidemic was really beginning to become evident to a lot of people in 2012. And it was becoming evident to our community leaders, to people who were supporters of the university. These individuals realized that for a long time, ETSU had been responsive to the needs of the region. So we started with a group of about 20 people that now has grown to 240 people. When we received the DIDARP grant, I think that really began to give us an infrastructure that supported these individual interests that were coming together in an interprofessional focus.
So the working group and the corresponding DIDARP project led to a number of community projects. I came on board in 2013 and continue to be a part of these projects, some of which are the Workforce Prevention Program and the Carter County Drug Prevention Project.
You know, the DIDARP staff and the working group really brought the solutions to us. The local government officials in Northeast Tennessee identified the problem. They led us to the answers and really helped us develop a solution that's part of the answer. And from that meeting came a commitment to work together to develop a strategy that would impact the effect of the opioids on our workforce in Northeast Tennessee. And
our Youth Opportunity Center is a tremendous asset to our community. We wouldn't be around without ETSU. The DIDARP program started our coalition. They started facilitating meetings. They really got the people in the community together and on board with this. And without them, I don't think that would have happened. And then they successfully wrote the grant that now funds our coalition. So they are very instrumental in everything that we're doing now.
DIDARP allowed for a number of opportunities for students to engage in research, from the drug take-back efforts to the communication studies.
At DIDARP, we really cherished the idea of training others, and so we brought in students and residents and fellows all into an environment where we were actively working on a very specific health gap. In the early part of DIDARP, we came together not only in the university but also in the community, and we had a number of law enforcement partners that we were working with, along with the DEA and of course all the Academic Health Science Center institutions. And that allowed us to put together a community program that was unlike any other. We've seen a lot of success in the Take Back.
In 2016, we received official designation from the Tennessee Board of Regents to serve as the Center for Prescription Drug Abuse Prevention and Treatment. This center has 4 separate cores. It has an administrative core, a research core, a community outreach and engagement core, and the clinical care core.
The center is highly interprofessional. It has a number of different members around the university, from medicine and pharmacy and nursing, social work. Public health is well represented there, but also has connections to the community.
Recognizing the significance of our center, the region's largest healthcare system and behavioral healthcare system reached out to partner with us to offer clinical care to the region in the form of medication-assisted treatment. Overmountain Recovery opened its doors in the fall of 2017 and provides state-of-the-art treatment to our region.
We are making a difference in the community. We're kind of that next step up that was needed. We're basically treating the whole person. The care we're providing is just above and beyond, I think, any center that's even close to us.
In addition to providing much needed care at the clinic, Overmountain Recovery allows for proceeds to be returned to the center for community-based prevention projects. It also allows an opportunity for real-time research into best practices for medication-assisted treatment.
There aren't places that are doing top-notch research in rural areas that have opioid treatment programs, so that's something that it's a missed opportunity if we don't do that, so we'll certainly try to inform the literature using that site.
Could you tell I was the only one that was scripted? I feel a little like stiff when I watch that. So that's our story. And now I'm going to walk you through some specific examples of that, being sure to leave time at the end to ask questions. All right, so we've been busy since 2012, putting forward a lot of grants and some peer-reviewed literature and doing a lot of presentations and established the center and Overmountain Recovery. So every elected official especially, and other people come to me, and I hate to use a bullet analogy in this time, but this is what I'm asked. What is the silver bullet? If I get elected tomorrow, what can I do to make a difference in this problem? And my answer is, you can know that there's no silver bullet. And they'll often say, yeah, but what's the silver bullet? There isn't a silver bullet, unfortunately. And this is our model. We think of this as an entire continuum. Dr. Mathis, who's in the room, is the primary author on a publication that really unpacks this at a very specific level, and explain it more than better than I can do, but I'm going to try. So a continuum of disease looks like this. We have people over here, most folks who do not misuse prescription medications or opioids, and we want to keep folks at that end, right? And then there's this initiation where they first begin to misuse, move into dependence. Any of us can be physically dependent on an opioid if we're on it for a period of time and go off. And then they begin to meet the criteria for substance use disorder, opioid use disorder, which is over a 12-month period. And along the continuum, there are lots of evidence-based ways to intervene, all along that continuum. Unfortunately, most of the general public don't know about those. So we really want to make sure that we get that information out there, and we use dissemination and implementation science. And that's a fancy but really cool new set of science that says, okay, sometimes there's 17 years between bench science and application in the field. What can we do to improve that? And how do we make sure that things are adopted and fit in the communities? So that's sort of our orientation in our center. We also know that the more money you spend on the left end of this, the better return on your investment. If people never start in the first place, we're saving a lot of money and loss of life. Unfortunately, we're more reactive as a society. We put out fires, we can see it happening, so we know that we can fix it, and we like to change that orientation. And so some of the things we're doing on this left side in primary prevention, again, you see dissemination and implementation of evidence-based programs and training for health professions. So you heard about the drug disposal program that we're doing. There are school-based prevention, and we've met with schools about integrating it into their curriculum. That's a harder sell than you'd think. There's community-based prevention, workplace prevention programs that are evidence-based, and healthcare provider training. This is one of our studies on drug donation drop boxes, the permanent boxes where you can dispose of your drugs. So more than half of people that misuse a painkiller the first time get it for free from a family or friend. And so making sure that you dispose of these properly and that we're not sharing our medications. And even when you might not realize it, someone might be looking in your medicine cabinet. Folks know if you've had surgery, so be sure to dispose of those drugs. And we're trying to look at what makes people dispose of their drugs, how far will they drive, and so that's some of our studies. Carter County Drug Prevention, you saw, they're doing amazing work in Carter County, implementing community level, individual level, I see a lot of nodding heads, they really are. And I'm just so honored to be a part of that group. And so I'm also honored that I had the freedom to leave my office and work with it and immerse myself in the community and support them. So again, there's Dr. Mathis, who's in the room, and my boss, Rob Pack. And so we talk about healthcare professional training. Is it as simple as saying you should talk to your patient about the dangers of opioid drug use? That's not an easy conversation, and our doctors weren't necessarily trained to be counselors or mental health professionals. And so we're trying to ask them. We've done some qualitative interviews. We're doing a quantitative survey to say, how do you talk to your patients, and how does it feel to talk to your patients? And so Dr. Mathis did her dissertation on this topic, and there's some publications coming out. And we're finding there are multiple factors. It's kind of complicated. Patient-provider relationship is a factor. How the behavior of the person is. What are your resources? What is your time commitment? And so through that initial study, we've noticed that there's three primary themes that we saw when we talked to doctors. And it is three primary ways that they're communicating. One is providing information. One is person-centered and supportive. And maybe they're blending some motivational interviewing. Maybe they understand this a little bit more and they're comfortable having these conversations. And others are the opposite of person-centered. They're counteractive. Sometimes we're finding that people are even getting fired from their primary care provider who does not maybe have the confidence or competence to have these conversations. So there's a lot of potential interventions here. So we're moving on along the continuum. Secondary prevention is when folks are misusing already, they're showing signs of dependence. What do we do there? So there are some things that we can do. The controlled substance monitoring database was a place where doctors check when they're giving you a controlled substance, or pharmacies check when they're giving you a controlled substance. And so that cut down doctor shopping a great deal. So folks that were beginning to be drug seeking were able to be sort of monitored and hopefully referred to treatment. So that was helpful. Also, there's SBIRT, screening, brief intervention, and referral to treatment. And we would think that it's sort of a natural thing to have integrated healthcare, right? We have physical healthcare, behavioral healthcare. It should all happen in the same space. Well, we know how hard that is. But SBIRT is a tool that allows primary care physicians and other folks to screen for substance use disorders, mental health conditions, and then have an intervention, a brief conversation, and then refer them to treatment if their score or risk level is high. And so Tennessee piloted an SBIRT project for, I think, 6 years, and many clinics still sustain that, some haven't, but it gets folks into treatment. And recently we do have some funding to reinstate SBIRT in ETSU family medicine clinics. So this is that new thing, and we're going to be able to put a certified peer recovery specialist in that setting, so we think that that might make a difference. All right, tertiary prevention. These are folks who are already meeting the criteria for opioid use disorder. Their risk level is much higher, and there are medications and interventions that are evidence-based. So we also know that mothers sometimes are becoming pregnant when they meet full criteria for opioid use disorder. And so we know that we need to intervene with those women. We also don't know a lot about the long-term implications for moms and babies who have NAS or NOWS. And so we wanted to be sure that we have a merged health system. We have a lot of data. We have high rates of NAS in our region. We should study this. But you have to have extramural funding. It's very competitive. We're ETSU. We're not Johns Hopkins. It's hard to get money to study this stuff. So we talked to the Junior League and we said, hey, you want to do something a little different? And so they were willing to fund us to draw down and build a database of records of babies who have NAS. And now we have access to that database. If anyone's interested in doing research, I can help you get access to this database and study it. There are some interesting outcomes already out being published in posters and conferences out there. And I think Dr. Kraus, if she's still here, she can tell you about that as well. So medications for opioid use disorder are to be used for women who are pregnant. There's a lot of misunderstanding about that. You can see here the recommendations from ACOG, the American College of Obstetricians and Gynecologists. So for pregnant women who have opioid use disorder, stabilizing them on medication, full agonist medication, buprenorphine or methadone is what is recommended currently in the literature. Not tapering because of the potential for relapse and danger to the infant. And so there are new studies that are practicing tapering women off of medication, but we haven't seen a lot of research yet that's proving that that would be effective. So that's still the recommendation. All right, so there are 3 primary medications that are effective at treating opioid use disorder. They are methadone, buprenorphine, and naltrexone. They're different a little bit. They can nearly double your chances of being retained in treatment. They're also controversial. So there's about a 10 to 15% success rate for folks with opioid use disorder who choose or are involved in an abstinence-based program. That means no medications, no impairing drugs. It's like 12-step programs, faith-based programs. There's about a 10 to 15% retention rate in those programs. It's over 30% when you add a medication. I know there's a lot of feelings about these medications and providers who are not doing a good job of wrapping around the appropriate treatment and who are overprescribing. Buprenorphine is also diverted on the street. But those 3 medications, let me just tell you briefly. Methadone is a full agonist, meaning it binds to the opioid receptor completely, meaning it has euphoric effects, and it can be dangerous for overdose because it also has depressant effects. And so that is usually controlled. You go to a clinic, you receive your dose daily, and it takes a while to earn a take-home dose. And so folks are stabilized pretty well on methadone. It's more affordable than the other drugs. Buprenorphine is a partial agonist, meaning it has some binding to the opioid receptor, but not as much. You don't get the same level of euphoria. You can go to outpatient programs. You don't have to go every day, and you get a prescription and you get it filled. Some folks need to be maintained on these medications. Some folks can taper. There are proper ways to do both of these things. We do know that there's a proliferation of buprenorphine providers in our region. Washington County was at 2,000% capacity at one time, and some who are overprescribing because you can make a lot of money doing this. So there are some nefarious folks out there, and there's a lot of diversion on the street. We understand that, but that doesn't mean the medication isn't good, and we're beginning to control that a little bit better. The last is naltrexone. It's a antagonist. You get no euphoric effect. You get no effect whatsoever from the opioid, and it's usually given in an injection for 30 days. It's $900 a month, and unfortunately, many folks are not coming back for that second dose, so retention looks a lot different for naltrexone, but people are way more comfortable with naltrexone. So again, we're talking about the stigma. I hear a lot of people say, why would you give a drug to help a drug problem? It's a crutch. You shouldn't do this. People can just, sort of white knuckle it, and that's how I did it. So there's a lot of stigma. There's a lot of pharmacies that won't fill a buprenorphine, or Suboxone is the name brand, won't fill that prescription. And so we're working really hard to combat this stigma. We don't tell diabetics when they don't follow their diet and they end up in the emergency room, we don't tell them to go off their medication or shame them for taking medication, even if they could control it by diet. But we do this for this disorder. And so I think it's really important to sort of begin to think differently. So we talked about the community pharmacy. That is something that we're studying, how community pharmacists are responding and how we can intervene and support them in understanding this a little bit better. So like I said, there's a ton of literature out there, not just one or two studies, meta-analyses about the effectiveness of buprenorphine and methadone at retaining people in treatment, keeping them off of illicit drugs, and keeping them alive so that their frontal lobe can wake up and they can rejoin society. Stigma, I don't know how many of you knew or were around when we opened a methadone clinic in Gray, Tennessee. Just a wee bit controversial. We had signs, we had picketing, we had 400 people come and tell us why they were terrified that these people were going to be in their community driving cars. Well, these people were already there, and it was important to share that there is more crime from opening a new convenience store than a methadone clinic. So, but I get it. I understand that it is scary and that their concerns were very real. Our clinic has been open for over a year. We've had no car accidents. We've had no trouble with the law. We are seeing over 300 people. No one is turned away for inability to pay. We have grant funds. We can now offer methadone and buprenorphine, and there are beautiful stories of success out there. So if you ever want to visit, let me know. I'm happy and very proud of being able to offer this service. So there's not only warring factions about opioid use disorder in the public and in healthcare, but within the treatment community itself. There are hardcore abstinence-only folks. Maybe that's how they got better, and they think that that's the only way. And then there's the medication-assisted treatment folks. So this is a New York Times article that actually covered one of our initial founders. This is an ETSU guy, a Northeast Tennessee guy, Stephen Lloyd. And he says, when I get a kid coming in that's been to 5 abstinence-based programs, he's overdosed, he's been Narcan 4 times, and he's 23 years old, I am absolutely going to talk to him about medication 100% of the time. Matter of fact, I'm going to try to talk him into it because it's his best shot at living. And so again, this tension is something that we're running into. I get asked every presentation about these medications. So what can you do to combat that stigma? You can learn a little bit, go to presentations, but just begin to use person-first language. These are not addicts. They're not people who are, having a dirty drug screen. They're persons with substance use disorder. They are people who are actively using or abstinent. They're relapsing, potentially. They're a person who is having a relapse. So Shatterproof and the Addictionary are good ways. If you don't know what terms are appropriate or person-centered, take a look at those 2 websites. So quaternary, we made that up. I think it's a real word, but we talk about it. It isn't the Institute of Medicine's prevention thing, and it's fun to say, but I put a question mark because it isn't a real thing that we know of yet. So folks who have received Narcan, which is they're overdosing and they've been brought back to life. There's a group in North Carolina called Project Lazarus. So this idea of bringing people back to life. So Narcan is a nasal spray. This next slide will show it. It's a nasal spray. It's very easy. If anyone in this room who is not on an opioid were to put it in your nose, it wouldn't do anything. And I know that there's a lot of feeling that it increases drug use if it's widely available. That hasn't been proven. But so we know that the interventions might look different for folks that have already been Narcaned 4 times, as Dr. Lloyd said. So those interventions might look different, and we're interested in how they might. There are now peers who are in emergency rooms trying to navigate people to treatment. But this is Dr. Sarah Melton. I think she actually might be here later today winning an award. And so her and her team have trained over 30,000 people in the use of Narcan. I carry this in my car. It is now in every ETSU dorm, as it should be, but it is also a controversial medication. I'll be honest. People think that you shouldn't have to Narcan someone more than 1 or 2 or 3 times. And so we're really, again, combating that stigma around substance use disorder in particular. We also know that oftentimes folks who have substance use disorder have criminal problems with the law. They misbehave, they steal, they do things that they would not normally do because their brain is hijacked by this drug. And recovery courts are new ways to divert people from the criminal justice system. All right, so that's it. So I'm almost done. Are we good on time? Yay. All right. So new stuff for the center. We're getting a new name. Yay! It's no longer a prescription drug problem, it's an opioid problem, and there are multiple factors. So we are going to become the ETSU Addiction Science Center, or ETSU ASK. So much easier to say. I told you about the ESPERT project. I'm the principal investigator for that. I'm super excited about that. We also have an ECHO program where folks who prescribe the medications, if they're having a challenging patient, they can get on and talk to other doctors and present their cases. My boss, he's in the news a whole lot. Sometimes you might see him or he might show up in your email thing, but I'm so honored to work with him because he is out there just leading these efforts in reducing stigma. And the Appalachian Regional Commission, ARC, commissioned a group to say, what could we do in Appalachian communities and build a recovery ecosystem? And so he was a part of that. He also chaired a group that said, okay, what if we actually win these opioid lawsuits? What if there's a universal settlement with millions of dollars, probably billions of dollars? What should we do with that money? How should we spend it? And we learned that with our tobacco settlement money, we didn't do a very good job. We didn't tell them how they should spend it. It built a lot of roads and did some cool stuff, but not around tobacco. And that's still the leading cause of death in the United States, preventable cause of death. And so they led a group. There's some recommendations. They're pretty cool, some a little controversial. We also are partnering with other universities across Appalachia. Instead of competing for funds, the Opioid Research Consortium of Appalachia, we're working together with other universities to share data and compete for NIH funds, not compete, collaborate for NIH funds. And this came out in your email box, or it did mine yesterday. Dr. Nick Hagaman received some NIH funding to study the community pharmacy. All right, so my research interests, well, they're a little bit different, but we talk about these evidence-based interventions and we know that they're available. So we've got science and we've got communities with problems, and there's dissemination and implementation science that can tell us how to pull these in. But I feel like there's something missing. I feel like that the narratives of these communities, their voices aren't necessarily always heard in the science as we know it. So I feel like Appalachian communities could tell us what fits for them and that we need to learn their stories. And that there's so many things about economic development, community narratives that we might be missing if we just stick to our standard version of sort of biomedical science. And so I heard about this place called Apple Shop in Letcher County, Kentucky. And they were doing a cool thing called a culture hub. And they were doing story circles. And so this is a transitioning coal community decimated by substance use disorder and other poor health outcomes. One woman calls it the dark night of the soul when coal went away. And so they got these people together and they did story circles. They were funded by Art Place America, and they said, tell us your story. And these were stories of hopelessness and despair. And then they said, okay, retell it. Retell the story that you want to make happen in your community. And so they had a play. And they've shown this play all over the community. And they built a culture hub, and they're having new economic development. So they're building and incubating small business based on culture and arts. I believe that's the kind of stuff that's really going to make a difference in Appalachia, paying attention to the communities and the people. But our science doesn't fit that yet. And so that's where I hope to spend my career. So I spend a lot of time digging into literature about historical trauma related to coal, social haunting, culturally transmitted traumatic stress. And my friend Wayne Coombs just put out this Why We Can't Solve the Opioid Problem. And sort of he says that our current model doesn't fit. We have to find new models. So I spend a lot of time and energy thinking about that. Luckily, I'm not alone. There's some people out there that are thinking in this way too. I attended some listening sessions with Art Place America and the University of Florida, and they're trying to look at the overlap between community development, public health, and culture and arts. And so I was able to weigh in. They have a recommendation. They went to NIH, I think, and said, hey, here's what we think. So hopefully this will catch on. And again, I'm not the only one thinking this. All right, so that's it. These are all the people that work in our team and that help support these efforts. I won't read them to you, but I'm happy to entertain any questions that you might have.
I think I've heard that you have spent some time on a fire truck. And I wonder if you could speak a little to what you're learning from this fire department experience you're having.
Yeah, so I went to Letcher County, and my preceptor said, yeah, we're doing cool stuff, but we don't know about health outcomes. Come measure it. I said, all right, that's what I'm supposed to do. So I showed up, and I started asking people about measuring health outcomes, and they said, we don't want to be studied. And I was like, oh, no. Okay. All right, CBPR, community-based participatory research, you do what they say, you immerse yourself. So I just began to immerse myself in the community. And that meant joining the local fire department because that's where stuff happens. And they are responding to the overdose. They're really being taxed. They're centerpieces in the community. They are where everyone goes. And so I joined, and I'm almost done with my training. I go at least once a month, every 2 weeks. I'm a really odd bird in that environment. I learned to take my blazer off. I change in the car. I wear T-shirts and jeans. And I'm learning a lot about the community as a result. So, and I can also do some things with how to stack the fire hoses appropriately in the top of the truck and how to pull them off and I'm learning so much. But yeah, they didn't want to be studied and they don't want to know their data.
Can you speak a little bit about the first responders experience? When they have to Narcan people multiple times and maybe they have stigma of their own?
Yeah, so that is some of the folks who are responding to overdose are certainly dealing with their own level of stigma. I see that shifting a little bit. They're also experiencing a lot of trauma. So if you're a first responder, you suck it up. You don't talk about that. So when I ask them, how is this affecting you to see people at the brink of death and to go to these same nooks and crannies and hollers over and over, and they're like, what are you talking about? It's my job. But we know that it's impacting them. And so learning to have that language and those conversations with them, I think, are going to be important. And there's some places that are doing that. But yeah, there's a good deal of stigma among first responders, but they're also amazing points of intervention. Because I rode along in an EMS vehicle with a drug-related call. And man, these folks are so patient and so loving, and so many opportunities for intervention there. So there's a lot to be learned from first responders.
About ideas, even if they're hard, the ideas you have for education or ways that we could intervene or do prevention, more prevention types.
Yeah, I don't have an easy answer for that because we have this rigorous set of things we have to teach kids, and we don't get to choose them at the local level. Someone from up above tells us what the core standard of study is. They don't give us a lot of money. They don't give us a lot of time. And so I think figuring out how to say there are 300 evidence-based programs, some are even free, that can be woven into the art class. The language art class, they're already connected to your core study and they're affordable. And it's not a lot of extra work at all. And so I think it's that misunderstanding of what prevention is and where it's available. So what I've tried to do is create some resource guides. There's still a huge barrier to pulling it in. And so I don't know what the answer is there, but I do think that it's easier than they realize. And we're just talking from public health and educators, and we're just often using the wrong language maybe. And sometimes I think requiring it at the state level as a part of the art class or the music class is the best way, but I never know. Is top down better, or I don't know. So.
Are the courts becoming more sympathetic in dealing with people suffering from drug addiction when they're before we the court relative to perceived crimes that they've committed?
Yes, not all of them, but yes, there's a huge movement in that direction, understanding that it's a disease, getting folks into treatment, preventing recidivism. So yes, I see softening, even locally. Groups that we couldn't sit down with because they thought we were the, methadone people are now having conversations with us. There's still a lot of discomfort around medication, so a lot of recovery courts will not allow their participants to receive the medications. So we're moving in that direction, but it's, I think they're constrained by the laws. If you break a law, you have to be charged and you have to go to court. And there aren't a lot of financial resources to support diversion. So I think even though individual officers are supportive, they're still required to maintain the law. So there's a lot of challenges, but short answer, yes, it's changing.
As far as like the law goes, in transitioning, being arrested for your drug charges and being put out, like how much are we actually implementing into that?
I think I understand. So you are the feelings changing? So what are we doing to apply that shift? Yes. And so I think that there's more and more funding for recovery courts. More and more people are being involved in recovery courts. I think in jails, there's more awareness. There's also awareness of your potential for overdose when you leave jail is very high because you think that the dose that you took when you went in is the same dose that you should take when you get out. And so now they're sending folks home, I know in Sullivan County with Narcan post-release. And so I think that there's a lot of application of harm reduction, access to treatment, awareness of this as a disease. But, every local jail is run by an elected official. So it's really, there isn't some big governing body except for the federal institutions that says how those things should be run. So it's just highly individualized. But I see that there are conferences of court professionals, judge conferences, criminal justice conferences. They're weaving this stuff in. So I think we're going to see a big shift in the next, 5 to 10 years.
So you're going to be doing stuff all across the spectrum. Can you talk about what's most cost effective and where it's the most ROI?
Yeah, it's primary prevention. It's keeping people from starting the first time. So usually misuse of a prescription drug or an opioid is around the age of 18, 19, and it's almost none before 11. It's very small. So if we can catch young people before 11, that's very helpful. But it isn't just about teaching them stress or coping skills or resilience or identifying trauma. It's about building communities that have less risk and more protective factors. And so there's ways that we can look at the entire community and sort of judge risk and begin to increase protective factors. And so I think it is always in primary prevention, but it involves so much more than substance use disorder. It involves a thriving economy. It involves recognition of cultural identities. It involves, do you feel bonded to your community? Do you feel alone? Do you feel isolated? How much trauma happens in a community? So I know that that's a complicated answer, but primary prevention always, preventing that first misuse. Hey.
Along with that, did you find that when you were doing your own research on when a community redid their own narrative, did some of those things come into play when they were doing the narrative?
Yeah. Yeah, they pretty much said, we need to keep our young people here. We need to be a place where there's hope and that we could have jobs, and not jobs that are from an external industry that's going to take millions of dollars that they make on our back. Not necessarily a new prison or a new coal manufacturer or coal. Their tagline is, we own what we make. And so even folks in recovery are running these local businesses. There's Black Sheep Bakery. There's a solar power company. And so, yes, their voices were loud and clear, and they were not about substance use. They were about building a place where people want to live and stay and feel safe and happy and thrive. So, yeah, the place really cool.
Dealing with pharmacies and filling these prescriptions, what would you suggest help with the stigma
Yeah, I hope our research can sort of shed more light on that. I think it starts with education. I do think it's how we train our pharmacists and how they understand this disease. You know, there's lots of ways to address stigma. Sometimes it's contact with a person. You know, there are multiple ways, but I wish I had a really good answer for that. But I do think it's the way that we train folks. Yeah, are there any pharmacists in the room? Yeah.
I'm a pharmacy technician.
Uh-huh.
That's why I deal with
Yeah.
patients every day. That's why I was wondering. We'll have people come in, like, calls, like 7 or 8 calls a day, like people showing up trying to fill food and everything. Like, every pharmacist has a different policy.
Mm-hmm.
Like, I know in Virginia, like, one of the pharmacists, she won't even, like, you have to prove that you're, like, a Virginia resident and all this just to, like, to fill it. And, like my pharmacist, he won't fill it. It's, like, you have to, like, already get it at CVS.
Mm-hmm. And again, many pharmacists are constrained by their corporate laws or corporate regulations.
Try to, like, allow more patients, and then we get calls from corporate saying, why are you ordering more people than ever?
Mm-hmm. And there's a fear that if you order too much, that you can get in trouble for having too much in stock. There's a number, but if you only have 1 or 2 pharmacies in a community that supplies it and no one else does, then you're going to order too much because you're trying to, you know, provide people. And it's, you know, is it a violation of folks, you know, rights to not give them the medication that they need? I mean, I think that there's a lot of concerns with not having a prescription or refusing to fill a prescription for folks. But I don't know what the answer is. I think all of the things that apply around stigma, training, education, but we don't have as easy an in for pharmacy training as we do with medical professional training. There seems to be a more natural fit for that so far. But it is a concern, and we're looking into it. So hopefully we'll have more research to share.
Are there any trainings locally for doing supplying Narcan?
They're everywhere. Dr. Melton, I can try to find out if she's doing anything locally, but there's a regional overdose prevention specialist, and I'm forgetting her name right now, but she hosts Sherry Barnett, and who does training. That isn't Sherry back there now. I was like, I see who it is. But yeah, she does trainings around the region, and you also can get a free dose of it if you participate in the training. Your insurance will also cover it. You can walk in right now to a drugstore, many of which don't require a prescription. Your insurance covers it. You can take it home. And honestly, Sherry would be mad if I said this, you don't really need training. Just call 911 and squirt it in their nose. I mean, honestly, I see Lindsay's like, oh no, now she's gone off the chain. But yeah, I mean, but yes, there are trainings, and I could try to get you connected. I have my cards, so if you want to do that, but you can also access it at the pharmacy, and they can tell you how to use it. Okay. Thank you.